Welcome to the Higher Education Center for Alcohol and Drug Misuse Prevention and Recovery webinar series. Today's program is entitled Addressing Opioid Misuse on Campus, Policy, Treatment, and Recovery. My name is Ken Hale, and I am the Associate Director in the Higher Education Center, focusing on prescription drug misuse prevention. Before we begin today's presentations, I'd like to go over a few technical points relating to this webinar and provide an overview of the Higher Education Center. This is a screenshot of the attendee sidebar interface. You should see something that looks like this in the upper right corner of your screen. The default audio connection is through your computer speaker. If you would prefer to join us telephonically, just select telephone in the audio box and the dial-in information will be displayed. Please feel free to submit questions for today's speakers by typing them into the questions box in the control panel. You may submit your questions at any time during the presentation, and we will collect these and address them during the Q&A session at the end of the webinar. We have also included a few polling questions during the webinar, and I will give you instructions about those along the way. The Higher Education Center is here to help colleges and universities develop, implement, and evaluate programs and policies to reduce problems experienced by students due to alcohol and other drug misuse. The center was reestablished at The Ohio State University in 2014 thanks to a generous grant from the Conrad Hilton Foundation. We are interdisciplinary in nature with strong partnerships between the College of Pharmacy, College of Social Work, Office of Student Life, the Generation RX Initiative, and Ohio State's collegiate recovery community. The Higher Education Center strives to contribute to student success nationally by providing a number of services to colleges and universities, including technical assistance, technology development, education and training, and research. We are here to provide information and resources, help facilitate the use of research and practice, drive innovations in prevention and recovery technology, and provide training and assistance to our member institutions. As you can see, our mission will be accomplished by data-driven solutions to alcohol and drug misuse, and with your help, we aspire to lead the dialogue on collegiate alcohol and drug misuse prevention and recovery in the national agenda. Our topic for today relates to one of America's biggest public health dilemmas. Drug misuse and dependency have escalated, drug overdose is our leading cause of accidental death, and the opioid epidemic is the primary cause. This epidemic affects every layer of our society and every community, be it urban or rural, and our college campuses are certainly not immune. The opioid dilemma has drawn attention from our political leaders, community coalitions, and advocates for enhancing support for prevention, treatment, and recovery services. From the U.S. Surgeon General to state and local health departments, healthcare providers have also joined the fight against this plague, which claimed more than 50,000 lives in 2015, over 60% of which involved opioids. But have our colleges and universities adequately responded? We know from data collected in the College Prescription Drug Study that more than 10% of undergraduates report misusing a prescription pain medication like Vicodin or OxyContin, about 9% report misusing a sedative like Xanax or Valium, and nearly 19% have misused a stimulant drug like Adderall or Ritalin. We know from the National Survey on Drug Use and Health that the traditional college student is around the average age when prescription drug misuse starts. And we also know that the vast majority of heroin users first misused a prescription opioid. So our institutions of higher education are positioned to make a difference in this public health crisis. But what policies for prevention should be established? How should we support those who need medication-assisted treatment? And what more can we do to support our students toward long-term recovery? Our speakers are here to answer these questions, and I am honored to introduce our first presenter. Dr. Victor Schwartz is Medical Director for the JED Foundation. He previously served as Dean of Students and Director of the Counseling Center at Yeshiva University and was Medical Director and Chief Psychiatrist in the NYU Counseling Service. Dr. Schwartz will help illuminate how college policies and federal laws intersect with this issue, as well as steps we can take to help protect our students from opioid overdose. Dr. Schwartz, it is a great pleasure to have you with us today.
Thanks, Ken. It's a pleasure to join you all today, and thanks for the invitation to join in with this program. As Ken mentioned, I'm going to try to give you a kind of broad overview as to what campuses can be doing across offices, both on the practical front and to some extent on the policy front, the sorts of things they may be thinking about, and then the next two speakers will be drilling down in a little bit more detail on some specific interventions and specific programs. So let's start out. I suspect many of you are who are dialing in are working either in the counseling services or the health services. I imagine some in health education and some in student services. I'm going to make a couple of comments about each of those things. But starting at the counseling service, I think it's really important, as Ken mentioned, the misuse of prescription medicines is fairly widespread on campus. There's some suggestions that some of those numbers may be going down somewhat, maybe partly because of efforts being put in place both nationally at the state level and on campuses to begin to address this. But, you know, as a starting point, I think it's stating the obvious to say that clinicians at the counseling service need to be alert to prescription drug abuse and other misuse as well. There's obviously, as noted in the slide here, clinicians need to be aware there is a significant degree of overlap, obviously. In this age, there are many young people who are dealing with mental health challenges, who are symptomatic in some ways, may also be using substances. In many cases, if you're seeing major psychiatric problems, you should have a high index of suspicion for some kind of substance misuse. And we also know that many of the things that are protective or risk factors for substance misuse and mental health conditions are overlapping. So life skill deficits, lack of connectedness, poor academic performance are both risk factors for mental health consequences and for substance misuse. And it's really important from the counseling service, if prescription is being done at the service, that there is coordination with the health services because, you know, obviously one of the main risks of prescribed opioids is the using them together with certain psychiatric medications, most classically benzodiazepines, which really increases the risk of overdose inadvertently. And I'm not seeing the capacity to move. Okay, great, thank you. It's really important, again, in terms of clinical services, there needs to be access to care. So obviously not everything can be done on campus. Campuses typically have limited resources. Most care is provided free of charge, which means that decisions have to be made about priorities. But it's important, if the campuses can't provide an array of services, that there are good conduits, good connections to local community-based services. For urban and suburban campuses, this is typically somewhat easier, although, again, it takes some work sometimes to identify settings for care for substance misuse that are going to be comfortable for students. In some big cities, some of the drug treatment programs actually will develop college student-based programs, and you know, it's important to work with your community providers and community clinics to try to coordinate care. One point that I think is really worth making too, and this is an issue for maybe the health service and the counseling service, but probably more so for the health service. A major source of opioids actually are dentists, and we often forget to include them in consideration of, you know, who really needs to be educated and where our attention needs to go in terms of trying to limit overprescribing of medicine. And again, coordinating across the campus, across both internal and community services, making sure that as much as possible you're sharing the information that needs to be shared both clinically and in terms of programs is really the best way to go. And let's go next. Okay, so looking at student education programs and health education programs, uh, it's really valuable, and I think it's essential. It's not just enough to provide careful medical and mental health care on services, but I think campuses, through their health education and student services offices, and actually it's great to engage student groups in this as well. Many campuses have a student health advisory board and groups, students who might be working with the health education department. And it's really valuable and important to coordinate messaging, make sure that students are well aware of the dangers of opioid misuse, and particularly of the dangers of combining these with alcohol and benzodiazepines, which again, as Ken mentioned, is also fairly frequent on campus. So students need to be aware of this. Efforts need to be not a one-shot deal. Those of us who are working on campus sometimes think, well, we did that kind of program a while ago, so it doesn't need to be done again. But remember, students have very short memories, and you may have done that program 2 years ago, and that's not often enough. It really needs to be repeated regularly. Think about when timing makes sense in terms of things like prescribed stimulants or misuse of stimulants. Obviously, we know exam times is a high-risk time around opioids, obviously to the extent that they're used in partying situations. Think about when there's school breaks. That might be times of higher use. And again, it makes really great sense to try to coordinate your efforts around messaging to the students with other offices. Make sure that you're not stepping over each other. And if you can, really try to be complementing each other's efforts. And if someone can move me to the next slide. Oh, there we go. Thank you. Okay. So in terms of the health center, obviously this is where primarily prescribing of opioids is going to happen, and we know that most of the misuse is through diversion of prescribed drugs. So there are a couple things that the health services need to be cognizant of doing to try to really mitigate the risk around this. Obviously, the clinicians on your health service staff and in the pharmacy need to be really alert to the risks of misuse and keeping an eye open for problems that might come up with a particular student. Obviously, you should not be prescribing opioids for minor injuries. It's really important to make students aware that in many cases for these kinds of things, the risk is way greater than the reward. And when there is a necessity, and again, thinking about if there is a dental clinic on campus, there's some larger campuses that might have access, but making sure that this stuff is also getting communicated to those in the community. Prescribing the lowest doses for the shortest periods of time is obviously the way to go. Unfortunately, people have over the years where very often you get approval in the pharmacy for a month of prescription for a time. People have just gotten in the habit of writing for a month, even though an injury may really only require 2 or 3 days of medicine. Obviously, giving the smallest dose for the briefest time is the way to go. It's really important to make sure your athletic staff at Big Athletics University are on the same page with all of you. Andrew Kolodny and I, a couple of years ago, developed some guidelines for sports doctors and athletic trainers, or some prescribing suggestions. Those are available, as you see on the slide, at the NCAA website. So feel free to take a look at those. I think they pretty much restate what I've been telling you. And something we often don't think about, but having the option for drug return. Many times, again, even students who are prescribed opioids don't wind up using them. They sit around, which increases the risk of diversion, which we should do what we can to mitigate. And having a way through your campus pharmacy to return those drugs is a really important thing. Okay, so pushing ahead, it's important for your campus first responders. I mean, I can't say this both enough and emphatically enough. there should be access to naloxone on campus. It's life-saving. It's practically risk-free. It's easy to give. So campus first responders, if the campus itself, as in some big universities, have their own EMT system. If you're using the city's EMT system, you should negotiate it with the city. There are obviously, and I note this on the bottom, local and state laws may impact the flexibility with which you can do this. There are various platforms now which have made it easier and safer to give naloxone in the event of an overdose. So all of the likely first responders, students who are at high risk, and anyone who could be a first responder, ideally, if this is consistent with state and local law, there should be naloxone available wherever possible. It has no risk of abuse and does have tremendous potential to save lives. So a poll question now, do you know, does your campus have access to naloxone for first responders?
So you should see in our first poll question, the question on the right side of your screen. Your responses are completely anonymous, but once you click your answer, you can't change it. So please hit submit to register your response and wait for the results to be shared. You have about 10 seconds to do so. Also, remember to submit your questions to our webinar host for the Q&A session at the conclusion of our program.
And if it's taking you more than 10 seconds to answer, then the answer probably is I don't know, which I see as the most, the most popular answer. Well, we don't know actually who's listening in, so it could be the people who are listening might not be in a position to know, but it would be really great if after this webinar was over, you found out from your health service or security department whether this is something that is being done and whether it can be done. Again, you may need to check your local laws about this, but in many cases, first responders certainly could be. If there's a campus EMT or local EMTs should be carrying naloxone, and you should know about that. I mean, it's an important thing to be aware of. Okay, so just a couple more comments to wrap up. All right, trying to. Okay, so it's important as a matter of policy. I knew we'd get to policy eventually. Medical amnesty policies are really important as a student protection factor. Medical amnesty policies are policies that allow for a mitigation of sanctions, that sanctions are lessened or removed for a student who seeks help or seeks help for a friend in the context of a substance-related emergency. And it's an important factor to allow students to be able to reach out for help quickly and without feeling worried that they're going to be thrown out of school or thrown out of a dormitory if somebody has overdosed or is in danger. This should be across the board for any overdose or any substance-related problem. These policies only work when students know about them, so there need to be efforts to make sure that students are aware that the school has a medical amnesty policy if it does, and understand what the limits and responsibilities of everybody involved are. Obviously, again, it seems sensible to consider that a student who does have some kind of substance-related sanction or problem at the school, the first approach should be towards doing assessment and finding out whether there's a need for treatment and what sort of treatment would make sense under the circumstances. It's really important for schools to have flexible leave policies. If students need treatment for mental health conditions, or for substance misuse conditions, we shouldn't be setting up barriers to their being able to do that and feel confident about getting the treatment they need and of being able to return to school. I'm just going to say that students should have access to substance-free housing, and you're going to be hearing a little bit more about what the campuses can do to provide a kind of community of support. And while mandated treatments tend not to be the best and most effective approaches to treatment, sometimes it's the best leverage you have if a student wants to remain in school and can manage being in school, and it makes sense to do that. It really can be very helpful for students who might have limited motivation to get them into care. And if we could just move to the next slide. Okay, great. And just so you should be aware, there is a federal law that allows schools to contact families when students have a drug infraction of any kind. If it's underage drinking, if it's use of illicit substances of any kind. But that's a judgment the clinicians and student services and student discipline people should make based on, again, the best interest of the student and the safety of the student. You're not mandated to contact family. You should also be aware that if students are turned over to the criminal justice system, that a felony around substances can result in loss of federal financial aid. So there can be major ramifications of a drug conviction. And you also need to keep in mind that convictions will obviously have an impact on someone's ability to enter the job market in certain important ways. So again, in making decisions about what process to manage a drug-related problem, it's just important to keep all these issues in mind. And thanks. That's it for me for now.
Well, thank you, Dr. Schwartz. You've really given us a good start to this webinar. We appreciate your thinking with us about policy and laws and so forth. Dr. Catherine McKee is a board-certified physician in family practice and addiction medicine. She previously served as the medical director at McKinley Hall Drug and Alcohol Rehabilitation and currently practices at the Ohio State University Student Health Center. Dr. McKee will introduce benefits and problems for using medication-assisted treatment for opioid use disorders among college students. Dr. McKee, thank you for joining us.
Thank you, Ken. I appreciate the opportunity to be here today. So just like patients with other chronic medical disorders like diabetes or asthma, with addiction, withdrawal, and treatment, physical symptoms must also be controlled. Many of those who are opiate addicted need to respond best to treatment that combines pharmacological and behavioral interventions. So addiction is a chronic, relapsing medical condition. We have a medical model in place with the infrastructure, but importantly, we need more collaboration with mental health services. And with changing insurance laws, there's more emphasis now on plans to cover addiction and mental health disorders at the same level of benefits as the general medical treatment. Of course, the ultimate goal is abstinence, but it's very difficult to treat opiate addiction successfully because the patients are so uncomfortable with physical cravings and withdrawal. So there's a really high relapse rate associated with this treatment. Medication helps to control these physical cravings, and if we can control and maintain some sense of comfort with these patients, we have a better chance of treating other conditions such as medical and psychiatric. Oops, let's see if I'm losing there we go. Sorry. Treat other medical and psychiatric conditions, and also give them an opportunity to take the time to develop life skills and other sober support systems. Medication-assisted treatment basically decreases the risk of relapse. So right now the goal is to expand access to and improve utilization of medication-assisted treatment together with the prevention of overdose. Here's a picture of a receptor. These receptors in the brain receive messages from correctly fitting neurotransmitters, just like a key in a lock. This is a picture of an empty receptor. This patient is likely to be very uncomfortable with pain or other withdrawal symptoms. Some substances fit perfectly and others only partially. So, whoops, I'm clicking in here. Here's a picture of a perfectly fitting substance in the receptor. This would be like morphine or methadone. So not only are we alleviating the symptoms of withdrawal, but also this person may have a euphoric effect as well. Methadone was the first in medication-assisted treatment. We don't use this much in college-age students. It needs to be in a carefully controlled situation with special licensure and regulations. People would come in every day for their replacement dose, their controlled daily dose, and this treatment is carefully combined with cognitive behavioral therapy and 12-step meetings. But there is a high rate of abuse often with this kind of treatment. So we don't spend too much time talking about that. A more convenient treatment has been buprenorphine. It's a semi-synthetic opioid. Here we go. And a partial opioid receptor agonist. Controls most of the physical cravings. And it's convenient. There's a sublingual film or a tablet, and now there's even an implant that is kind of new on the market. Physicians can prescribe this in their office, and it usually just requires monthly physician visits with maybe urine drug screen checking, and also conversation about what kind of meetings and counseling situations the patient is in as well. One issue is because this is a controlled substance, this medication can be abused and diverted. And sometimes the taper is uncomfortable. It just really needs to be a very slow taper when the patient is ready to come off of the medication. Here's a picture of the receptor with the imperfectly fitting buprenorphine. So it's got a limited opioid effect. It helps quite a bit with physical cravings, but doesn't give so much of the euphoria. Here's a picture of a Suboxone film strip. These melt under the tongue. Like I said, there's also Subzolve and Subutex. There are different film or tablets available, and also an implant that can last up to 6 months of treatment. Here at Ohio State University, we started recognizing that some of our students coming back from drug detox and rehabilitation needed to be maintained on their medication. They were having difficulty following or finding prescribers in the community, and so we sought to create a Suboxone maintenance assisted and recovery treatment protocol, and spent some time with our collegiate recovery community folks as well as our counseling and consultation folks developing a protocol. Since we're not a detox or treatment facility ourselves, we're just looking to maintain students who have been stable on their medication. So these are some of the criteria we're looking for: students with 12 months stable treatment. They would come in monthly for physician visits and urine drug screening. We required 3 weekly meetings, most of which are on campus. The Suboxone does require a little bit of special consideration because it is a controlled substance, and physicians who want to prescribe have to be through some special training through SAMHSA and get a DEA waiver. So our program is designed for students who are in maintenance so that they can conveniently continue their medication while in the college setting. Another medication that is not a controlled substance, this is naltrexone, which is an opioid antagonist. It gets in that receptor and completely blocks opiates from getting in. It blocks all opiate effects, so as an antagonist. One of the issues for patients before they start, they have to be completely abstinent from opioids for 10 to 14 days. It can be prescribed as a monthly injection or daily tablets, and there is also a new implant that's becoming available. Again, we would recommend monthly physician visits with urine drug screening and discussions about their community support. This medication, because it is not a controlled substance, is not diverted or abused and is safe to discontinue abruptly without withdrawal. One of the drawbacks is the injections are very expensive and may depend on how their insurance covers as far as what kind of copays. One thing before I get into naloxone, some of the problems in general with medication-assisted treatment is, as I mentioned with the naltrexone injectable Vivitrol, the cost can be very high. Also, access to treatment. There aren't a lot of physicians who are either qualified to treat or who have the interest in treating patients with opioid addiction issues. In support groups, there is still, in some areas, a bias against medication-assisted treatment, and so those clients may feel very uncomfortable in 12-step meetings and other support groups. And also there needs to be an ability to collaborate very closely with your mental health providers, counseling, and sober support systems. Naltrexone, I should go back one. The naltrexone is especially good for students who might be very compliant and very motivated students. Okay, let's go back forward. Okay, so the naloxone, as Dr. Schwartz mentioned, is an opioid overdose treatment. We have these opioid reversal kits in our pharmacy at the Student Health Services Pharmacy. It includes discussion with the pharmacist about education, recognizing when there is opioid overdose, and how to use this kit. It is very easy with a nasal atomizer. It's just injected and sprayed up into the nose. The idea is that any family member or friend could use this kit, and our campus police do carry it. We would like to make these kits more available. There are a lot of programs where kits are offered free of charge. I know here in the state of Ohio, our Ohio Department of Health is active with that, and you should check your local health departments. So here is a question, a little case study for you. Your patient is a 26-year-old medical student who is graduating and soon moving into another city for their residency program. They have recently tapered off of their Suboxone after 3 years of stable recovery, and they are not on any medication now. They're anxious about surviving the stresses of a new location, work, and loss of their community support. And how can they maintain their recovery? What do you recommend? Take a look and choose the one that you think is best. All right, good answers. Restarting the Suboxone, yeah, I think the best thing would be to not have to go there if you didn't need to. So you could just really ramp up the 12-step group support, go to extra meetings, really kind of push them to do that. The other thing would be to discuss naltrexone injectable. Those would be probably my two first choices. I was looking for the naltrexone in particular, but there's always the issue of finding a new provider in the new city. And not very many would advise just forget it, change your plans and just stay here and be treated. So yeah, good job. Just exactly the thoughtful kind of answers I was looking for. So what's ahead? We are hoping for new medications. Safe and effective, preferably not controlled substances themselves. Ideally, they would be affordable with no other side effects and without abuse potential. Some of these might even be old medications, which we find new indications for. Medication-assisted treatment is always best done in combination with recovery program of therapy, community support, and treatment of comorbid issues and life skills building also. Thank you.
Thank you so much, Dr. McKee. Well, it's really no exaggeration for me to say that Sarah Nerad is a transformational advocate for youth recovery and serves as Director of Recovery for the Higher Education Center, as well as Program Manager for Ohio State's Collegiate Recovery Community. As a young person in long-term recovery from drug and alcohol addiction since 2007, Sarah is dedicated to advancing recovery systems for college students. She will conclude our webinar by discussing the needs and challenges of being in recovery on a college campus and how collegiate recovery communities can help meet those needs. Sarah, thank you for all you do and for sharing your insights with us today.
All right, good afternoon, everyone. This is Sarah Nerad. I am the Director of Recovery for the Higher Education Center. I am also a young person in long-term recovery. So I have the privilege of getting to kind of wrap up our webinar talking about collegiate recovery. And here at Ohio State, I work directly with our collegiate recovery program and all of our students. So why do we need recovery supports on a college campus? You know, what we know nationally is that most of these students have already done some school and then are coming to us after maybe completing treatment or taking some time off. So they've got that foundation underneath them. So for these students that are coming to us directly from another sober living facility or a treatment program or even mom and dad's house, you know, coming then to a college campus, there's all this new freedom. They've got less structure, they have less supervision. So, you know, we're asking young adults who, you know, we already struggle with making good decisions and, you know, being responsible sometimes to really do some grown-up stuff and be super responsible. And that's a lot to ask sometimes. You know, and then, you know, coupled with that, they're thrown into an environment that has high rates of substance use. Many of them are leaving behind their established recovery support system. So especially these students that are moving from, you know, another location, or they're coming to us straight from a treatment program, they're leaving everything that they've known in their recovery, and that is really, really hard to do. And so then they're coming to this campus, and, you know, they either aren't supposed to be friends with the people that were friends with in their active addiction, or, you know, they don't know anyone anyways, and so then how do you find other people that are supportive of your recovery? And so it's really hard to develop a new peer group that is positive, they're pro-social, they reinforce your recovery and living a sober, healthy, active lifestyle. You know, and then there's students. College students are some of the busiest people out there, and so how do I balance recovery and school? How do I do these things at the same time? How do I prioritize them? And how do I fit it all into my schedule? So we obviously need recovery supports on campus for these students. So the solution to that would be to establish collegiate recovery programs. So these are supportive environments within the campus that reinforce the student's decision to disengage from addictive behavior. So they allow them to do school and recovery at the same time, so they do not have to sacrifice one for the other. So that is the definition of collegiate recovery programs. So the benefits of collegiate recovery programs is that they extend the continuum of care. You know, we know that your chance of relapse drops below 15% after you have 5 years of sustained recovery. So collegiate recovery programs essentially can give you that ongoing recovery management and support potentially for 5 years. So it's really critical that we have these. My favorite is that parents can worry a little bit less. You know, they've invested so much in saving their students' life, you know, resources, time, worry. You know, my parents got a lot of gray hairs from this process. And, you know, to now know that I'm at a college campus where I am supported and people are there looking out for me is a tremendous relief and benefit to them. Collegiate recovery programs also increase access to higher education for folks that, you know, maybe would have given up on this dream, or they thought that their you know, criminal history or the fact that they've dropped out of school, or maybe their resume, you know, they don't have legal jobs that they could put on there, you know, they think that they're not going to be admitted, or that we're not going to want them. And so these programs instill hope and give people second chances. And so with that, they increase retention and graduation rates. Our students stay enrolled in school, they maintain their recovery, and they do well. And that is what we want to see. So we've got a question for you all to answer. So does your campus have a collegiate recovery program? Similar to some of the other poll questions, hopefully you know, and if not, by the end of this you'll know where to go to look to see if you do have one. All right, glad to see that, you know, almost a third of the folks on here have a collegiate recovery program. Looks like some of you are getting you're working on starting one. Some of you have a recovery-based student organization. 39% of you said no, so hopefully we can chat after this to figure out how we can help you get one. So for those of you that don't know, definitely check out Transforming Youth Recovery and the Association of Recovery in Higher Education and the Higher Education Center here at Ohio State to learn more about how to start one and how to find out if you've got one. So collegiate recovery programs are all over the country. They've been around, for a number of years. 1983 was when the first one started. So, they're at, teeny tiny liberal arts, private schools. They're at large land grant institutions. They're at red states, blue states, you name it. These programs are everywhere. So your campus too can have one. So how to get involved? If you're on this webinar and you don't work directly in collegiate recovery, how can you get involved and support students in recovery? So definitely partner with them on events. A lot of us do sober tailgates, we do presentations on campus. The students are amazing speakers. So if you have a staff meeting or you have some sort of event about addiction or recovery or mental health, have these students come and talk. There's nothing like hearing, a real life story and testimony. Celebrate National Recovery Month. This is every September, so there's a lot you can do on campus, from speakers to rallies to maybe a recovery walk on campus. So that's a great way to raise the visibility, help reduce stigma and misinformation about addiction and recovery. If you have a program on your campus, help disseminate their information. I know I am always trying to get the word out about what we do or our new meetings, new activities, so help promote, help spread the word about the program. And refer students by doing a warm handoff. Don't just hand someone a business card or a brochure. Actually link them directly with the collegiate recovery community. Either walk them over, do an email introduction, do a phone call with them and the CRC staff. That increases the chances that they actually get connected and then maintain their recovery. So if you don't have one on your campus, start advocating for one. We've got great schools we can benchmark, and we can help you figure out how to do that. Or start a student organization. There's a lot of power that the students have and the ability to come together and mobilize assets on campus. So that is it for me on the recovery portion, and I will turn it over to Ken.
Okay, well, thank you, Sarah, and thank you, Catherine and Victor. We will now respond to questions submitted during today's presentation. As a reminder, you can still submit questions through the questions box in your attendee control panel. So, Dr. Schwartz, I'd like to start with a question for you. And that is, let me kind of paraphrase this. When we consider the opioid epidemic, it seems that our colleges and universities are significantly behind other factions in our communities in terms of addressing this critical issue. What else, in your mind, can we do to get the attention of our college and university leaders to enhance much-needed prevention, treatment, and recovery resources? That's a tough one.
Well, so I'll respond to the premise of your question first, which is I think you're correct that colleges are somewhat behind in addressing this problem. I believe partly there's a conceptual challenge here. It's really hard for university administrators, student life administrators, health service leaders to often acknowledge that opioid misuse is happening on campus. And, I think it is important to point out and be fair that the rates are probably on average among active students somewhat lower than the rates of misuse you might find in the local communities or in the state in which the university is sitting. But that said, I think there has been this conceptual challenge. It's a little bit akin to what I think we saw 20 years ago around college student suicide, or 15 years ago, that there was a real almost conceptual antipathy and difficulty acknowledging it. Obviously programs like this are a good start. I think getting student leaders to speak up, because very often students actually have more impact than they imagine on what goes on campus. And state health authorities, I think, where there is more activity, need to be really bringing the state universities, and I don't mean just the public state universities, but the universities within their states, together to really make sure that they all are aware of the challenges and begin to take the sorts of actions we talked about today.
Great. So thank you very much. Great answer. Let me shift a question to Dr. McKee. Catherine, can you tell us what significant challenges or sources of resistance you might have encountered here at Ohio State in trying to introduce medication-assisted treatment on campus? Certainly there must have been some pushback along the way.
Well, at the time that I presented my proposal, about 2 years ago, was the only physician. I was the only physician that was certified to prescribe Suboxone and had the experience or the interest. We started with the proposal there at Student Health Services. My director was very supportive, which was key. And then it was important to garner the support of our partners within student life, such as our counseling and consultation folks, and also our collegiate recovery community, which we are so grateful to have here on campus. Just like any other university, probably, there's just a lot of bureaucracy and kind of, not really red tape, but a little bit of resistance in what are we doing? Is this the kind of thing that we should be doing here on campus? And do we really have a problem, or do we really want to acknowledge that we have a problem that needs to be addressed in this way? And I think with the continual conversation in the press about the opioid epidemic, we were propelled forward in our continued work on this protocol. So it was just kind of a collaborative effort. It took a long time and a lot of partners around the table, but I think we were able to come up with a pretty good plan.
Thanks, Kathy. Pretty good plan indeed. It's working pretty well and still growing. So, Sarah, I've got several questions for you. I'm going to morph together. One of them is from me, actually, and I'm going to add two other things here that other people have sent to us. So, I've been around Ohio State a long time, and this is a big mammoth, thing that's slow moving. And so you've pretty quickly changed the culture of recovery here in ways that are really fairly amazing to me. So I'm wondering, how, if I'm someone in a different place, what magic you have a power that's unique to you, but what advice do you have for people on trying to make that work somewhere else? And then secondly, from our listeners, do you have suggestions on how to engage students on campus, and specifically any tips on how to find students in recovery on campus?
Thank you, Ken, for being one of our biggest supporters and champions on campus, and for me personally. And I think it's key to find your person that's going to lead this effort on campus. And I don't think they have to be in recovery. A lot of us are, but I think it needs to be someone that can speak really passionately about the need for collegiate recovery, use, recovery messaging. So we want to go out and we want to talk about the positives of recovery. We want to get people bought into our vision and get them excited. And then ultimately have them be someone that students are going to want to come and hang out with, because sometimes that's what we do. We're hanging out, we're building community. And so the person needs to be someone that they want to come and connect with and relate with and learn from. For me, I was just, I don't know, maybe stubborn, maybe, just kind of clouded by what I wanted, but I was dead set on, we're starting one of these programs and we're going to do whatever it takes. And, by having kind of that faith in, what I wanted to do, we were able to accomplish quite a bit. And now it isn't just me carrying the torch. And so I think when you're doing this work, if it does start out as just you need to get other people bought in, so that it is not just you. You have many people that are, carrying the message, talking about why this is important. And so then how you go about finding and engaging students, that's something that we still struggle with here at Ohio State, and I know other schools do as well, because this is a hidden population. But we did some obvious things. We, those of us that are in recovery, we started going to the young people's recovery meetings in town. And we found a lot of students that way. We started to get as much press as we could possibly get. We made sure that our marketing materials were in the colleges and in the programs that were helping professions, social work, public health, things like that. Any class related to addiction, we made sure that the professors knew us. And then once we found this kind of core group of 3 to 4 students, they then all knew other students. And so it kind of grew from there. But the bulk of our students come from word-of-mouth referrals or from us being off campus, presenting at conferences, being at community events. So we've really had to build a presence both on and off campus to get referrals.
Thanks, Sarah. And I'm going to stick with you. One more question here. So again, one from me and one from, I'm going to pair it with something else that came in. So I happen to know that you came from Texas Tech, and you came up through college in a well-established recovery community. So I'd like to hear you share with our audience the power of that for you personally in terms of why you're here now and the things you've been able to do. And then how do you justify the need for a recovery community?
Great question. So Texas Tech was an unbelievable experience for me. I transferred there when I was 20 years old. I had 3 years of recovery, and I picked that school because they had one of these programs, and I knew that being a young person in recovery, moving for the first time, you know, and not just moving, like I was moving 9 hours away from home to a town that I didn't know anyone, that I was going to need this program. I was going to need support. And so that school and that program was a catalyst for me to get connected and to find community. And it was there that I got to learn from, you know, leaders in the field, and they were willing to allow me to shadow them and come to events and pick their brains. And so, you know, investing in our young people as young professionals and as young leaders is really important to me because people did that for me. They gave me opportunity to lead. Even though I was young and even though I was in recovery, they saw beyond that and what I was able to do and the abilities that I had. So that was just a phenomenal experience for me, and I'm very grateful that they accepted me into their program. So how do you justify a collegiate recovery program on your campus? Certainly start collecting the data. What do you know about, you know, from the drug and alcohol policy that you have on campus? See what they know about students that have been dismissed from the school for drug and alcohol related infractions, how many transports you have, right? So start to collect the data you've got, and then look out at your community. Do you have a really strong young people's recovery community? Are there treatment centers? So you kind of want to start seeing what is there to build the justification and the referral source. I mean, really, when we started Ohio State, I wish we could say we had, you know, put together this super fancy proposal and that we had all these students. We had one student that was emailing us. We had one student. And it also helped that that school up north had a program, so we could say if they've got one, we need one. So maybe, you know, play to the fun rivalries that we've got to help justify it. But it started just with some students that were passionate and were continued to send emails. We need one of these. We're struggling. We need support. We need community. So that's how we started to justify it. And then looking at, you know, the data on just in general young adult addiction and recovery. I mean, college, this is, you know, a culture where, you know, folks drink excessively and they party, and like these things seem to be just acceptable in this culture. And so all of that we kind of use to help build the case for support, knowing that addiction's a young person's disease. It starts here. So happy to help share any of the information and resources that I have about how we justified creating one and continuing to fund one.
Great. Thank you, Sarah. Your transformation process and the things you've done here really are amazing. I want to shift to Dr. McKee, and I'm going to bundle a couple of questions here for you, Kathy. First of all, how did you show your administration the need for the medical assisted treatment program? And because apparently some other administrations seem to be in denial about this issue. And then also maybe a more specific question in terms of naltrexone. You know, what do we do in case of a relapse for a student who is on naltrexone?
Well, one of the ways that I presented the information that I had received from counseling and consultation, who had been they had been in contact with students who were having difficulty finding providers. They were getting the questions about where can I find providers who are able to prescribe for me in a responsible way. I think it helps when some folks in the administration are maybe personally moved by the issue. Most of us nowadays have someone in our life, someone we care about, with an addiction issue or even alcoholism. And so, you know, and here in Ohio, we just have a huge opioid crisis. So I mean, it's in the news every day. We have overdoses every day. It's a very public thing, and to connect with our local public health department, trying to get information about our particular area of the state. I don't know. I think you just pull in all of the pieces that you can, and then I think the big thing is I think they're kind of afraid to admit that there might be a problem on campus. It's maybe not good PR. But if you realize that these are just people and we are a subset of the rest of the world, and especially big college campuses that are within big, you know, cosmopolitan areas, we're going to attract a lot of people of a lot of different persuasions, and some of those people are going to have this problem. And we need to be able to address that. And here on campus, we call it to provide the what most excellent student experience. What is it? The extraordinary student experience. We want these students to succeed just like every other student on campus. And in order to provide that kind of support, this is a service we need to offer. About naltrexone, that's a tricky issue. You know, naltrexone originally, the question was, if someone relapses and they're using opioids, how can we get them through that 10 to 14 day period of, you know, abstinence before we can prescribe for them again? And you know, it was originally used a lot, or it was thought to be helpful people coming out of prison where we thought they had a long time of sobriety. Or students, maybe people who had been tapered off of Suboxone and who were doing pretty well, kind of short term at least, with hyped up maybe group and 12-step meeting attendance. So I think and then they might feel a little shaky as life goes on and they are invited to parties or family gatherings. So I think what you need to do is tell them daily meetings, daily connection with their sponsor. There are medications that we can provide for comfort, such as clonidine, which helps with that goose flesh feeling, that creepy crawly feeling, or ibuprofen for the muscle aches, or trazodone to help them sleep. Anything that's not a controlled substance, though. But there are medications that we can use that work pretty well short term, as long as the patient is also getting that sober support system that they need. That is really kind of the most critical thing, and you just really ramp that up, meeting a day, 3 meetings a day, whatever it takes to get you through that time.
Great. Well, we're about out of time. We have received a lot of questions, and we're not able to answer all of them here today. So what we'll be doing is we will send these out as a PDF by the end of the week. So we'll respond to those who were able to be here. One final question that I'll briefly address is the question came in about drug take-back days and do we do them and how. We do them on our campus through our Student Health Center pharmacy. Law enforcement's involved. There are guidelines by our Board of Pharmacy. It's all state-specific. DEA has tried to simplify this, so it's becoming easier. If you're interested in that, communicate with us through our education center, and we can put you in touch with the folks in our pharmacy who have made that happen. We are really grateful to each of the speakers for volunteering to share their expertise and perspectives about this important issue. I always learn something from all 3 of you, and today was no exception, so thank you for being here. And thank all of you for joining us today as attendees. Please keep in touch with the Higher Education Center via email, social media, or through our website at hecaod.osu.edu. We truly appreciate all you do to prevent alcohol and drug misuse among our nation's most precious resource, the students in our colleges and universities. Good day.